we treat plenty of lower molar sites with max implants. The difference here is that you've got greater density of bone. That's probably the most prominent thing about treating the lower sites. So you're more likely in the lower sites to use a max drill than in the upper jaw. You'll notice in the protocol that I've described to you in the upper jaw, we didn't use a max drill. We drilled to 6, took out the tooth, used a max tap. There was no mention of a max drill. In the lower jaw, we do the same protocol, but there's a higher chance that you may need a max drill. Right, so that's the one difference. In the lower site, we also prepare starting to the lingual, trying to stay away from the buccal. But in moving the site to the lingual, you also have to consider lingual undercut. Fortunately, with the device being strongly tapered, it usually avoids the lingual undercut to a large extent. And that's another nice thing about having a strongly tapered implant. So the protocol we follow here again is simply drill through the tooth. Cut the crown off, drill through the tooth. Most of these molars are pretty easy to drill through because they've got spread roots. One of the other criteria which is quite important, both for upper and lower jaw, is that when we drill through the tooth, what we want to do, and it's an important take-home point, is to drill beyond the apices of the roots into bone if we can, if the anatomy allows for that, if the nerve position or the sinus position allows for that. The opposite is that if you don't, if you drill to the exact point of the apices or short of the apices of the teeth, and then you then eject the tooth, all you've created is one big hole. There's no purchase point for the implant. So we learned that lesson some time back. So it's very important to take that on board. If you drill beyond the apices of the teeth and then you eject the roots, you can see at the bottom of the socket the point that you're aiming at, the osteotomy apically that you're aiming at, and that becomes fundamental to positioning the tap and positioning the implant ultimately. So just look to that. Obviously, if the roots are very wide and you've got a core of bone here, then having to go beyond the apices falls away somewhat. But if the roots are any narrower and you at the same depth of the root apices, you haven't really gained anything by drilling through the tooth. You must go beyond. If you follow the protocol of drilling to 6, taking out the tooth, tapping with a 7, then most of the time in the mandible, you're going to end up with a max 7. If you move beyond that, it would be because you haven't got enough primary stability with your 7mm tap. And what you would then do is take the next size tap, 8mm, put it in the site, and find the primary stability. And that's the reason you'd move on from 7 to 8 and maybe to 9. In the mandible, however, to change dimensions from 7 to 8 in dense bone is less likely than it is in the maxilla because this bone is quite dense. And if you intend to go bigger, if for some reason you want to have an 8 body or a 9 body, you probably in dense bone won't be able to generate that with a tap, and that's where you may need to use the max drill. So you need to be a little bit flexible in your application. But I would suggest to you that your protocol should always be to first try the max 7. If you don't have to go beyond that, then don't. You've got enough done. And in that regard, the criteria for prosthetic stability on an external hex is that a 5mm diameter platform on an external hex will support a molar single restoration. A 4mm platform on an external hex we don't consider stable enough for a single molar restoration. So the max 7 is a sweet spot. It's adequate for primary stability in bone, but it also has an adequate prosthetic table of 5mm. So if you don't need to go beyond that, don't do that. We can see that in a lower case, you'll always see bone voids, mesial and distal, because that's where the square root anatomy comes into it. It'll look as though the implant doesn't have any coronal stability, but of course on the buccal and the lingual, which you're not seeing in this view, you normally in a molar, lower molar, will have some engagement of bone. But notice that these voids without any graft material will fill up completely. So there's no need to put expensive material in there and induce possible issues long term. Simply let it heal, the body will take care of it. And it's quite remarkable to see how the bone is maintained way beyond coronal to the prosthetic interface here. And that's pretty much the standard, it's not an exception. Again, drill beyond the root apices if the anatomy allows for it. It just makes for a much more predictable placement. So we've done twist drill through the root. We've taken a radiograph to verify the depth. Take this radiograph to verify depth as soon as you can. Don't wait until it's too late to make corrections. The smaller the drill you have inside when you take a pilot radiograph, the better off you are, because you've got enough volume, you've got enough structure around you to make corrections. The typical thing that would be off here is the axis, the mesiodistal axis and the buccolingual axis, and obviously the depth is important when the inferior alveolar nerve is at play. So we expand the osteotomy through the tooth, up to 6 millimeter drill again, take the tooth out, and then tap. These radiographs on the left cluster here is by Dr. Andre Hutting. He's a periodontist, ex-South African qualified, who's practicing in London. He's got extensive experience with the Max. He's part of the publications on Max with Ghent University and now University of Nijmegen in Holland. And he's also busy with a PhD study on the Max implant and an article which will appear early next year, which I co-authored in Journal of Perio and Restorative Dentistry, to look out on surgical technique for the Max. That will be a very good summary of this entire lecture. But he's doing exactly the same, drilling through the tooth. There's his pilot drill, takes a radiograph. He's using the osteotome or try-in part to verify placement. In all of my material, instead of that, you'll see the tap. He does tap. My sense of it is that if you take the picture with a tap in sight, you've got a representation of what the actual implant would look like, and that makes ultimate sense to do that. So in this case, again, a tooth with chronic pathologies, we've drilled through, we've got the tap in position, we take a picture with a tap, and that represents the implant. If we're good with it, that would be the same size as the implant we choose. In this case, there was graft material placed. This is quite an old case. I wouldn't find any need to do that today, and you can see the healing. The evidence is that whether you graft this or not grafted, the healing, it fills with bone, and I prefer not to have the graft material there, especially non-resorbable products, because they seem to be a problem long term. Right, so there's the case, drill through the tap inside. Notice the depth of placement here below the interproximal crests of bone. And the implant at 3 months. Notice the infill of bone, significant infill of bone in this case, with no grafting. That's a phenomenal response from the socket. And you can see at 10 months. Look where we started, this void. Look where we are at 10 months. Only 10 months. That's a 7 millimeter Max implant, 5 millimeter restorative platform. A pretty long restorative length, but nice and stable on that passive abutment. So 7 millimeter Maxes are pretty standard in the mandible. Look at these extensive voids where these pathologies are, and they fill in over time. So we started out moons ago with incorrect armamentarium, incorrect protocol. There's also prosthetic misfit here. You can see this was made from plastic cylinders, which we wouldn't dream of using today. We don't need to. We've got better things. And we've got site-specific tools, and we can do predictable therapy in these molar sites.